Laura, and thanks for everyone for having me back. Some of the content we're going to discuss today, I'm going to go through pretty quickly because it mirrors what we discussed last time, but it's kind of hard to talk about improvement strategies for antibiotic stewardship without making sure that we're all on the same foundational understanding of what we're talking about to begin with. So apologies if it's a little bit duplicative, but we'll try to move through that relatively quickly. I am, as you may remember from previous webinars, pretty informal presenter. Don't hesitate to interrupt me and ask questions. This is for you, not for me. So I would appreciate hearing from you in real time, and I will try to monitor chat as well as just feel free to interrupt me if something doesn't make sense. So my clever name for this is the ABCs of ASP for CAHs, trying to make it entertaining and exciting. So really what we're talking about is antibiotic stewardship programs and critical access hospitals. You all know from previous webinars, I work at Stratis Health. I'm a program manager here. We're a small independent nonprofit located in Minnesota. We do a lot of work around quality improvement and safety with healthcare providers across the spectrum of care, and really have a specific niche with regards to working with rural providers. And I'm here with you today in our capacity as the Rural Quality Improvement Technical Assistance Center, or ARQITA. That is funding that we receive through the Federal Office of Rural Health Policy, which is also where the Oklahoma Flex program that Laura works for receives their funding. And we have the opportunity to work with the state Flex programs and the critical access hospitals that they support in their quality improvement efforts. So typically what that means is talking about the Medicare Beneficiary Quality Improvement Project, or MBQIP. So our objectives today are to just review the importance of antibiotic stewardship for CAHs. We talked about this last time. Just again, want to do some ground leveling there. Identifying the core elements, and we're going to analyze the national CAH performance. You may remember from last time that we talked about the Oklahoma CAH performance from 2017. We want to just take a quick look at what that national CAH performance was to give you some indication of the hospitals that were selected and participated in some focus groups that we did in April to kind of compare what their performance is against their peers nationally and give you a sense of who we were talking to. And then we're going to review those suggested strategies. That's what we're going to spend a bulk of the time on. So if I'm going too quickly at the beginning, feel free to slow me down. I want to make sure that we have plenty of time to talk about the strategies, but also want to make sure that we're all on the same page. As with all things healthcare, there's a lot of acronyms involved in antibiotic stewardship. These are just a few of the ones that I know that you're going to see on the coming slides. ASP is Antibiotic Stewardship Program. You know what a CAH is. The CDC is the Centers for Disease Control and Prevention. You know CMS. Electronic Health Records, MBQIP, and the National Healthcare Safety Network are some of the acronyms that get used here. So again, we discussed this before. The goals of MBQIP are really to help critical access hospitals get them all reporting on a common set of rural relevant measures, and then measure and demonstrate improvement with the goal of improving patient outcomes. We're able to do that because when you're all reporting on a standard set of measures, we can compare your performance against others nationally, which is a really great outcome of MBQIP. So antibiotic stewardship, F4HP decided to focus on this a couple years back based on there's been a lot of buzz nationally about this, but antibiotic use we know has well-known unintended consequences, and C. difficile is one of those. We know that inappropriate antibiotic use is contributing to that growing crisis of antibiotic resistance, and that antibiotic stewardship programs have been shown to mitigate those threats by improving infection cure rates, reducing C. diff infection rates, reducing adverse events, and reducing antibiotic resistance overall. So antibiotic stewardship was added to MBQIP as a patient safety measure with the goal that all critical access hospitals fully implement an antibiotic stewardship program by August 31st of 2022. The way that F4HP is analyzing this and determining whether or not this is being met is by looking at the National Healthcare Safety Network's annual facility survey, which all critical access hospitals are asked to fill out on an annual basis in NHSN. And on that survey, there are a multitude of questions, a handful of which crosswalk to determine whether or not your facility is meeting the 7 core elements of antibiotic stewardship as defined by the CDC. This visual should be familiar to you all by now. This represents where all of the data comes from and goes to for your participation in NBQIP, and antibiotic stewardship is represented there in the middle as being reported to the National Healthcare Safety Network. It is a little bit of a nuanced measure in that although prospective payment system hospitals do complete the annual facility survey, they are required to complete the survey in order to be able to submit healthcare associated infection data, which is a requirement for them for other payment programs they participate in. We don't analyze the data for them in the same way. Antibiotic stewardship in and of itself is not a measure for PPS hospitals the way that it is for critical access hospitals, but the CDC does have that data for all hospitals nationally that are participating in reporting. There's a number of resources that are available to help you with the NHSN annual facility survey. You have to be enrolled in NHSN, you have to add the patient safety component, and then you have to complete the survey by March 1st of each year. Any questions at all about where antibiotic stewardship falls within NBQIP and kind of the reason behind the importance? Okay, we'll keep moving on. So National CAH antibiotic stewardship implementation. This should be familiar as well. The core elements of antibiotic stewardship are leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. And so in order to meet the goal that F4HP has set forth, we need all critical access hospitals to be able to answer questions that indicate they have implemented these 7 core elements. Nationally, based on the 2017 annual facility survey data, so the way that the annual facility survey works is that it needs to be completed sometime between January and March of each year, and the survey is meant to reflect the information that was true in the facility the year previous. So in 2018, the survey that was submitted reflected 2017 actuals in facilities. The data that was just submitted in the early part of 2019 reflects 2018. That data just became available and we haven't had a chance to analyze it yet. So we're still looking at the 2017 data as kind of our measure for comparison at this point. Of the hospitals nationally, of the 1,345 hospitals nationally in 2017, 85% of them completed the survey, which is pretty phenomenal. And of those, so out of all of the hospitals nationally, 661 of them had actually indicated that they're meeting all 7 core elements. So half of the CAHs nationally answered questions on the survey that indicated that they had met all 7 of the core elements. We discussed this last time, but we really want to hit it home that there are multiple ways to meet the core elements of antibiotic stewardship. In some cases, there's 1 question per element, and in other cases, there's up to 5 questions that you can answer, and depending on how you answer each of them, you could just do one of those 5 things and get credit for that core element. So within the leadership area, there's the written statement of support and there's salary support. And you can see that there are a lot more critical access hospitals that have that written statement from leadership than that have received salary support to work on antibiotic stewardship. So while 69% of CAHs nationally are meeting that leadership core element, there's a lot of room for improvement. About 1,000 critical access hospitals either didn't do the survey, or of those that did are not allocating salary support for the work. And arguably that it's going to be pretty hard to make dramatic improvements in antibiotic stewardship if you don't have dedicated time and resources for the project. With regards to accountability, there's just the 1 question: is there a leader responsible for stewardship activities at your facility? 78% of CAHs nationally are meeting that requirement, and you can see the breakdown of the types of provider groups or staff that are responsible for antibiotic stewardship in the orange box there. 542 critical access hospitals indicated that a pharmacist is leading up their antibiotic stewardship work, which isn't surprising. And then 261 said it's co-led. Typically when it's co-led, we see that a pharmacist is involved in that as well, based on the additional information that people indicate. So a lot of pharmacy involvement. With regards to drug expertise, is there at least 1 pharmacist responsible for improving antibiotic stewardship at your facility? And nationally, 79% of CAHs said that that was true. And as we talk about what we learned from the the focus groups, although we were looking at very high performing critical access hospitals with regard to antibiotic stewardship, not all of them had a pharmacist on site. So it is possible to be a high performer without having a pharmacist on site. And almost, I don't think any of the participating hospitals actually had pharmacy coverage 24 hours a day. So it's also possible to have a robust antibiotic stewardship program and be using your consultant pharmacist during your off hours. Action is the real where the rubber hits the road with regards to antibiotic stewardship. There are 5 questions on the survey. Answering any one of them in the affirmative will give you credit for that core element. And so you could just do one of these, and if you're doing all 6 of the other core elements, you'll have met the goal that the Federal Office of Rural Health Policy has set. However, we really strongly encourage critical access hospitals and state flex programs to take a particular look at action. This is really the heart of antibiotic stewardship, and arguably it's hard to imagine that we'll have a lot of impact on antibiotic stewardship and antibiotic resistance if hospitals are only doing one of these things. So while it's a great place to start and it's important to start somewhere and to get that low-hanging fruit out of the way, our recommendation is that you really be looking at these more intensely and thinking about how you can implement as many of them as possible. So when we did the focus groups, we actually limited those who were invited to the focus groups to those hospitals. If they were part of a larger health system, they needed to have indicated they were doing all 5 of these action steps. And if they were an independent critical access hospital, they need to have indicated that they were doing at least 4 of them. So we've got facility-specific treatment recommendations. Often that takes the form of an antibiogram. Reviewing courses of therapy, that's the review after prospective review, and communicating the results of prospective review with the prescribers. Prior approval for specific antibiotic agents, requiring documentation of indication for antibiotics, and then conducting an antibiotic timeout at some point after 48 hours from the initial orders. So while you can see that 80% of CAHs nationally indicated in 2017 that they were meeting the action core element, only 11% of them indicated that they were doing all 5 of these things. So once you've met the standard for implementing an antibiotic stewardship program, it doesn't mean that the work is done. There's still opportunities for improvement there. With regards to tracking, this is another area that we focused on. We only invited hospitals to participate in the focus groups that indicated they were doing all 3 of these activities. So were they monitoring antibiotic use at the unit, service, or facility-wide level? Are they, if they are, and if they were doing that action step that required facility-specific treatment recommendations, are they monitoring adherence to that protocol? Because we know having a protocol in place doesn't necessarily mean it's being followed. And then if they were doing if they were requiring the documentation of indication, were they monitoring that as well? So some of these are if that, then this. If in the action area you're not doing those 2 things, you can't be tracking on them. So there's really an order in some cases to how you're able to go about implementing these things. And some of them are pretty nicely, obviously, go together. If you're going to require documentation of indication, are you monitoring it? How are you sharing that information with your providers? So 69% of CAHs nationally are meeting the tracking core element. Only 18% of them are doing all 3 of the tracking activities. Reporting really looks at, so you're monitoring and tracking on that data. What are you doing with it? So are you sharing the results of your prospective review with your providers? And are you sharing reports about antibiotic use at the facility, unit, or service level with your providers? So again, just as with action, it's nice to implement policies and procedures, but if you're not tracking and monitoring them, they arguably maybe aren't having much of an effect. And then if you're tracking and monitoring them, but you're not sharing that information with the folks who are responsible for actually doing the work, it's not really all that useful either. So it's a multi-step process. And nationally, 72% of CAHs are meeting the reporting core element by doing one of those 2 things. With regards to education, this is really interesting, and when we get into the results of the focus group, I was really blown away by how many of the CAHs indicated that this was one of the most difficult things to do. It is one of the easiest boxes to check because it really is just, are you providing education to clinicians and other relevant staff on improving antibiotic use? And that can look on a number of different ways. But making it meaningful and making sure that people are walking away and having buy-in into the program is what our focus group participants indicated was a big difficulty for them. 70% of CAHs have indicated nationally that they're meeting this core element. Any questions at all about the national data? And again, once you have these slides, you could compare them to what we reviewed on the last webinar, where we walked through how Oklahoma is faring in all of these 7 core elements and get a sense for how you're performing against the national. So now we'll move into the real meat of it, which is the suggested strategies that we gathered from high-performing CAHs. So a little bit about the methodology. We stratified critical access hospitals nationally into 2 groups, those that were independent and those that are part of a larger health system. And we did that because we've heard anecdotally from independent CAHs that they have different resource and support needs and obstacles than their counterparts that are part of larger health systems, where they may have a more robust antibiotic stewardship program already underway. We then identified high performers based on the 2017 NHSN annual facility survey data, which we just reviewed at the national level. And we also ensured national geographic distribution utilizing a random sampling method to identify 30 independent CAHs and 30 CAHs that were part of a health system who were then invited to participate in the focus groups. With regards to defining high performing, I talked about this a bit already. They had to have implemented all 7 core elements as indicated by the 2017 survey. They had to have answered yes to at least 4 of the 5 action questions for those that were independent, and all 5 of them if they were part of a health system. And then they need to answer yes to all 3 of the tracking questions as well. The breakdown ended up that we conducted 4 2-hour-long focus groups, 2 with independent critical access hospitals and 2 with those that were part of a health system. We sent the questions to them in advance and encouraged them either to invite or get insights from other team members before the focus group calls. And then we also have sent some follow-up questions to all of the participants to gather some more discrete data. So in the focus groups, we heard a lot of anecdotal data about their antibiograms and how they were developed and how frequently they were updated and what such. But when you have 10 to 12 hospitals on a call, you're not getting the exact same type of information from everyone. We really wanted to be able to get that granular level of detail to say, of the 35 hospitals that participated in the focus groups, X number have an antibiogram that's developed specific to them, and kind of what that makeup looked like. So now we'll go through the 7 core elements, and you'll notice that I've merged a few of them together. So if you're familiar with antibiotic stewardship and kind of the rollout that the CDC has overseen across healthcare settings, they started with hospitals and they identified the 7 core elements. Then they rolled it out to nursing homes and they used the same 7 core elements for nursing homes. And then they rolled it out to outpatient and they limited it to 4 elements of antibiotic stewardship. But really, it's just a merging of the 7 core elements down to 4 core elements. So they're really one and the same, and some of these can't really be separated from each other. So we rolled leadership and accountability together. Many of our focus group participants identified that this was one of the easiest elements to meet, and anecdotally, I think that's because you can't really have an antibiotic stewardship program without having leadership and accountability in place. These really are the first 2 things that need to be met in order to make the program work. If you don't have support from leadership, if you don't have someone who's responsible for implementing at your facility, you're not going to get very far. Driving factors that were identified, if you remember back in 2016, there was a proposed rule that came out from CMS that summer. And in there, it was proposed that antibiotic stewardship would become part of the conditions of participation for hospitals. At the same time, the Joint Commission, likely in response to that CMS proposed rule, set forth in their standards the core elements essentially as they were written out in the proposed rule. It was right around the time of the administration change, and we're not really sure if that was why it kind of fell into a black hole. That proposed rule never made it out of the proposed rule phase, and it actually has now lapsed in its time period. So if CMS is going to move forward with requiring antibiotic stewardship as a condition of participation, it will need to come out in the form of a new proposed rule. But in the meantime, a lot of hospitals took heed and a lot of programs took heed. So the Federal Office of Rural Health Policy took that as a note to implement antibiotic stewardship into MBQIP. Many of you are probably participating in the Hospital Improvement and Innovation Networks, or HINs. They're also working on antibiotic stewardship. The Quality Innovation Networks, QIOs, have been working on antibiotic stewardship in outpatient settings. Nursing homes have had to implement it in the meantime based on their conditions of participation. So there's been a lot of work in this area since that 2016 proposed rule came out. 2016 was kind of a magic year based on the feedback from the focus group participants of when they really dove into this subject more deeply. Roughly half of the focus group participants indicated that they had salary support for dedicated time for antibiotic stewardship, and that's in comparison to that 26% that we saw nationally. When it came to drug expertise, there were 34 hospitals that ended up participating in the focus groups in total, and 29 of them had pharmacists on site. So again, that highlights the importance of pharmacy. I think it also highlights that 5 of those hospitals were really very high performing hospitals and didn't have pharmacy on site. So it doesn't have to be an obstacle that's insurmountable if you don't have pharmacy at your hospital. Many of them indicated that they had sought out Society of Infectious Disease Pharmacists, or SIDP certification. And some of them did identify hurdles with after hours coverage with regards to that drug expertise. Some of the ways that they overcame those hurdles were through telepharmacy. If they were part of a larger health system, they were using video phones or Zoom, as we're using right now as a platform, to connect with those folks who have drug expertise at the larger tertiary facilities that they're related to. The most common referenced resource for after hours coverage was through their contract services that they just have for pharmacy in general, using them for remote verification. So ensuring that the contract service is using the same protocol for verification and prior approval as the pharmacist who's on staff would during the day. And then many of them indicated that they limited their formulary so that after hours clinicians had access to a certain array of antibiotics to ensure that they had antibiotics available, but they just weren't able to get those hard-hitting antibiotics without prior approval. For action, we're going to go through them one by one. So there are those 5 action steps that can be taken. The first is the facility-specific treatment recommendations. Focus group participants said that the biggest barriers were who are going to be involved in making that decision. So for some of you, if you're a really small critical access hospital and you have a lot of big personalities among your providers, how are you going to come to an agreement about what antibiotics you are going to use as your facility-specific treatment recommendations when provider A has always used this antibiotic for this issue for as long as time has existed, time immemorial, and they're not changing their process. So a lot of what we heard about was provider buy-in, clinician kind of being, obstinate or stubborn about making changes to their prescription processes. Another big barrier there is obviously low volumes and limited resources. So it's difficult to have a regularly updated antibiogram if your patient volume is low, and how are you determining what is the most appropriate for your facility if you don't have sufficient resources to develop an antibiogram or sufficient volume to develop a robust antibiogram. Most of the focus group participants are using a facility-specific antibiogram that's updated at least annually. They are doing that by working with health system affiliates, nearby universities, or other partners to assist in developing that antibiogram. Others indicated that they're using empiric guidelines if they don't have an antibiogram available. And then once they've determined what those facility-specific treatment recommendations are, many of them are leveraging their electronic health record to drive the appropriate prescribing behavior. So if you're requiring that documentation of indication, when you have a drop-down box that says, here's what the indication is, then the recommended treatment based on your facility's specific treatment recommendations automatically pops up. And if the provider wants to override that, they have to do additional clicks, which we all know is one way to get providers to do things, is to make it as few clicks as possible. And then in many cases, that would require prior authorization from a pharmacy if they're going outside of what the facility's specific treatment recommendations are. Prospective audit and feedback. So this is some of the biggest barriers. We're determining who is going to conduct the audit. So what are the resources that are available at your facility? And then getting clinician buy-in to that process as well. Are they open to receiving that feedback from whoever's doing the audit, and are they going to change their behaviors based on what they learn? Most of the focus group participants said that a pharmacist at the critical access hospital, or if they were part of a larger system, the infectious disease physician, were responsible for those audits. And then they had to go about determining what to share and when, which depends on the culture of the team. So in some cases, they were doing those prospective audits, and then they were individually sharing data one-to-one with providers. In other cases, they were rolling up the individual data to the aggregate level and sharing it with the team. And so then in that case, when it's aggregate, it's de-identified. And there were a couple of examples where there were physician-specific unblinded data being shared with everyone. So depending on what the organizational culture is at your facility, these are just a few of the options that you would have for sharing that prospective audit data. Prior authorization for specific antibiotic agents. We talked about this a little bit with regards to drug expertise. One of the biggest barriers is the lack of 24-hour pharmacy coverage. So you've got a policy and protocol in place and it's followed during business hours. But then after hours, you're needing to work with your consulting service or having telepharmacy available to be able to cover that gap. And then getting clinician buy-in, again, prior authorization. I've always prescribed this for this. I don't need someone to tell me that I can't. So making sure that everyone's on board and understands the importance of this part of the process. Most of the focus group participants had pharmacy on site during the day and then after hours coverage through their contract or their health system affiliate, and they limited their formulary as we previously indicated. And again, those EHR workflows really were used to drive recommended treatment when possible, so that they weren't getting to the place where they really needed prior authorization for specific antibiotic agents because they weren't requesting those specific antibiotic agents. They were using the facility-specific treatment recommendations. Documenting indication for all antibiotics really was hinged completely on the electronic health record. So the biggest barrier that was identified was the lack of EHR functionality for those that said that this was difficult. For those that said that this was easy, they leveraged their EHR, which required documentation of indication in order to place the prescription. So for those that have that built into their EHR, it kind of bypasses the need for clinician buy-in because it's a hard stop. You have to put it in. If there isn't EHR functionality, getting that clinician buy-in is essential because those that don't have it built into their EHR are having to use open notes and then conduct manual audits of those notes in order to ensure that that documentation is happening. Some of them have gone so far as to tie adherence to that protocol to the clinician performance review. So they receive reports on a regular basis about whether or not they're routinely documenting antibiotic indications. And if they aren't, then that has a negative effect on their performance review. The final action step is the antibiotic timeout. Again, if the EHR has the functionality to support this activity, it's kind of a slam dunk. You get some sort of a pop-up that reminds you, and there's a hard stop to say, okay, it's been so long, now you need to do this activity. Documenting that the timeout happened, if the EHR requires that you document it, it's pretty easy. If the EHR doesn't, then you need to figure out where it's going to be documented and how you're going to audit and track on that. Regarding the timing of the timeout, most of the focus group participants noted the question in the survey references after 24-hour or 48 hours. Usually this timeout isn't happening until closer to 72 or 96 hours because you're waiting for culture results. So it's not possible to do the timeout until you have the culture results and can determine if you need to change course with regards to treatment. Some of those that didn't have the EHR functionality, or even those that did, offered some alternative and additional options for making it part of their standard workflow. So In one case, pharmacy is sending nursing a report daily of how long patients have been on antibiotics. So they're really relying on nurses to bring it to the attention of the clinicians. Some of them have built it into their daily rounds that they review appropriateness of antibiotics, and others have pharmacy manually generating a note to the chart to remind the clinician to complete a timeout. So again, these could be in addition to or instead of, in lieu of, that EHR functionality to drive a timeout. Tracking and reporting, these are two core elements under the hospital listing, but they are merged together for the outpatient setting, and they really make sense kind of as one. So we pulled them together here. Most of the focus group participants indicated that they're sharing tracking data at medical staff meetings, so making sure that you get this on the agenda. When can you bring antibiotic stewardship to the attention of your clinicians? Many of them are using scorecards or dashboards to convey their performance data. Again, this harkens back to determining what the culture of your organization is and what level of specificity do you get into. Is this provider specific, blinded? Is it provider specific, unblinded? Is it aggregate to the facility? What do you need to do at your facility to meet the cultural needs and also drive improvement? Examples of some of the additional metrics that practices indicated they were doing: days of therapy per 1,000 patients, their immune dosing, frequency of use for specific antibiotics. So if you determine that you need to decrease your fluoroquinolone use, that you're tracking on the frequency of use for that specifically for a given amount of time until you get it down to the level that you're comfortable with, and then maybe identify the next one on the list. How many orders were accepted or rejected during the prior authorization process, and then that IV to PO conversion rate. They really talked about leveraging knowledge from tracking and from their EHR to help drive their workflow. So again, taking the information, like if you're wanting to decrease the frequency of use for specific antibiotics, not making them the default or the first one in the list of dropdowns that come up in your electronic health record is one really relatively seems relatively simple. I admittedly do not make changes in EHRs, and I know that I can oversimplify what I think would probably be a pretty complex process. But just some of those, you know, what are kind of profound ideas. You just do them. If you change the order of the listing of medications, you can really change the behavior of the prescribing. And finally, education. So again, many of the focus group participants said that this was a major barrier. It's really easy to tick the box, but it's difficult to make this education meaningful and to actually garner clinician buy-in. So they said, again, get it on the agenda, get it in front of people over and over and over again. This should not be something that can just be met by completing a learning management system module once a year. If you really want to make an impact on antibiotic use and resistance in your communities, you need to be bringing this up to your clinicians routinely. Medical staff and nursing meetings are a great opportunity. Some of them also referenced leveraging webinars and newsletters. They're building it into their orientation and onboarding processes for new hires. And then they've identified nursing and physician champions so that the conversation continues outside of those meetings where whoever's responsible for antibiotic stewardship might be presenting, and then you have physician and nursing champions who are carrying the message forward on the floor. So that takes us through what we learned from the focus groups. I want to make sure that I pause there and give people a chance to share or ask questions about any of those recommendations that we received. You're a quiet group today.
Hi, Sarah. This is Laura.
Yeah.
I had a quick question. I know you talked about education and how it could be an easier one, but it's the buy-in's the hard part. And I know we talked about this on a national call, but what are other state offices of rural health doing to help in the area of education? Or is this a feasible area for us to provide support?
That's an interesting question. I don't know that I have a sense of what the other state flex programs are doing. We can certainly look into that. And part of our next steps after completing this round of feedback from high-performing CAHs was to go about getting feedback from state flex programs about their approaches to this as well. So we'll be working on that later this summer. As far as what they can do, I can tell you from my experience in Minnesota on a different project that I work on, we have a statewide collaborative, what's called CHAIN, the Collaborative Healthcare Associated Infection Network. And it is comprised of a number of different stakeholders at the state level who are interested in reducing healthcare associated infections and improving and reducing antibiotic resistance. So we put on, as a collaborative, a couple of free educational opportunities at different times during the year. We have one that focuses on HAIs, one that focuses on antibiotic stewardship, and of course those overlap, so they really kind of both focus on each other. And that's we think that's a really nice way to bring a lot of people together from a bunch of different settings to talk about things. So that's one example. And our State Flex program is involved in that work, as well as Stratis Health is involved in that work as it relates to our Quality Innovation Network grant that funding that we have, contract with CMS. So there's opportunities to look into what are the other stakeholders in the state doing and how can you best collaborate and make sure that the same consistent messaging is getting out there, and are there opportunities to provide that kind of education in a collaborative way.
Okay. Well, I would like to also pose the question to the group of folks that we have on the call. How can we, as the Oklahoma Office of Rural Health, how can we help you? We want to help. And so, you know, out of everything we've talked about today, what are some areas that you feel like, hey, we could really use your assistance in this? Okay, well, I'll let everyone think about that one then.
And I'm just going to review a couple of quick resources, but then I really do want to hear from you all. What stood out from you? Be thinking about what stood out to you of the focus group responses. Was there anything that was surprising, or anything that you thought, well, yeah, that's a no-brainer, or here's the way we did it that was different? We want this to be useful to you, and we also want to gather your feedback so that we can continue to grow the resource. So some of the resources that we have available to support you, there's the annual survey resources. The CDC has put together an implementation guide for antibiotic stewardship at small and critical access hospitals. Some folks out in the Northwest region of the US put together a Jumpstart Stewardship Toolkit, and it's really a guide that they walk through during a full day workshop with participants to help them think about how they're going to go about implementing antibiotic stewardship at their facility. And then we will be releasing out the outcomes of our focus groups soon. So be watching for that. It will be coming at sometime this summer. So I hope that folks will participate in this. We really do want this to be interactive. So my discussion questions for all of you to consider: what have been the biggest barriers for your hospitals related to antibiotic stewardship? What strategies from the focus groups are you going to take away with you? And what are different strategies that have been successful at your hospital that I didn't mention today?
This is April from Carnegie Hospital, and I think our biggest barrier right now is the time frame when we get our culture results back. It typically takes anywhere from 2 to 7 days for us to get a result back because we have to use a resource lab. How are the other hospitals managing that problem?
I'm sorry, can you say one more time? So with regards to the resource lab.
Yeah, it just takes a relatively longer period of time from that 24 to 48 hour hard stop that you were talking about.
Sure. Yeah.
For us to get those results back. So are the other hospitals, are they working that into their policy, stating that, you know, once culture results are back, or are they setting like a hard time?
They're saying once culture results are back. So
okay.
What becomes a hindrance is if you do build it into your EHR, what's the magic bullet in terms of when to have that prompt come up? So if it's possible to have it be tied to when the culture results are entered into the EHR, that would be amazing. What we heard from the folks who were engaged in the focus groups was most of them were setting it at 72 or 96 hours, and they weren't making it a hard stop because they weren't sure if they would have the culture results by then.
Okay.
So it's not a perfect science, unfortunately.
Okay.
But your question is a good one. So initially when I read through I've been working on antibiotic stewardship for a while, and initially when I read through them, I just saw the 48 hours. So I kept referring to it as a 48-hour timeout, and I've heard that in numerous other circles. And what we're hearing is that that's not realistic. Even at the larger facilities, 48 hours isn't realistic. It takes longer to get the results back. So it's the way that the question is worded is actually after 48 hours. So it was a good clarification for me to hear from the focus group participants too, that it's really usually more of the 72 to 96 hour range. Does that align with your experience as well?
Yes.
Okay, yeah. I'd be interested to hear from you if you do come up with any strategies, or if you're able to leverage your EHR to support that, how you go about doing it. What it sounded like on the focus groups, based on what I heard, was they're setting the alert to be a bit later, but it's not a hard stop. It doesn't preclude them from continuing on with anything, but it will continue to pop up and remind them if they haven't done it.
Okay, thank you.
Absolutely, thanks for the question.
Also, if you'd like to submit a question or comment via the chat, I'll be watching it as well.
Other thoughts on this, things that have gone well for you? Any takeaways from the focus groups that you thought, oh, we could do that? That might be a relatively quick win.
I think my biggest challenge is knowing, having the knowledge of the antibiotics and knowing what to do with them as far as when you're doing the audits and looking at them. And I mean, there's pharmacists who have done fellowships in that area, but I wish that there was more publication of kind of basic information that we should be looking for.
Sure. So do you know, at your facility, are you using an antibiogram?
Yes.
You are, okay. So part of that
But
prospect
it's not facility specific because we don't have enough data points.
Sure. So what's the geographic spread of your antibiogram?
About 30 miles.
Okay. So is it developed by a larger facility that shares a similar population with you?
Yes.
Okay. Yeah. So I'm not a clinician. I'm not a pharmacist. So I can't speak too much to the specificity of that review process. But what I can say is that there were some hospitals, as I indicated, that didn't have antibiograms, either didn't have one that they were using or didn't have one specific to their facility. And what they were frequently doing then was utilizing the empiric guidelines. There was a resource, and I need to look into this, and I'll have to get back to Laura to pass it along. I'll make a note. I know that there was a state that had put together an easy access, I want to say that it was the TMF, had put together a resource where you could easily access all of the empiric guidelines in one place, so you don't have to go searching for them, if that would be of use. Is that the kind of thing that you're looking for?
I think it'd be a start and it'd be helpful.
Sure. Yeah, I will follow up with the contact. It's coming back to me who told me. So I will reach out to them and see if they can share that with me so we can pass that along.
That'd be great.
Thanks for the question.